Thank you very much, and thank you, Jonathan, and thanks, Aurora, for inviting me. And I'd like to thank the SAGES for having this opportunity to work together and deliver this important guidance to our members. These are my disclosure. I'll give you a brief background, what about the need for these guidance, as well as how we developed it together. Take you back to the 11th of March, 2020, when the WHO announced the start of the pandemic, following the rapid rise of cases across the whole globe. With this unprecedented time and nature of the disease presented a number of challenges to the surgical community, to us all, about patient safety, about staff safety. There has been a contradicting information across the internet and social media, specifically about the safety of laparoscopic surgery, and as an urgent guidance was needed given the rapid escalation of the pandemic. However, we had very little information about the virus, and definitely no information at all about the virus and minimal invasive surgery. And we didn't have any experience how to deal with this level of pandemic, given the staff deployment, staff sickness. And there has been a global state of uncertainty and panic, specifically with explosion of data and social media and the number of tweets about COVID surgery and the impact between them together, and the rapid rise of guidelines and position statement with very little evidence to support them. So how we started, we worked very hard within each society and in between the two societies. We formed a steering group to develop the guidance, and we worked very closely with the executive at both societies. We acknowledge there is a lack of evidence, but we draw from extensive resources and educational as well as research, guidelines, development committees, task forces at both societies. We had knowledge of similar viruses, and of course, the WHO kept announcing a number of recommendations that they were helpful. Also, we utilized clinical experience from sharing practice across the globe. And I'd like to thank here Horatio Aspen for bringing together not just the leadership of EAES and SAGES, but he went further and invited global expertise where we used to meet every Friday and to share practice as well as to share experience about this disease, which formed the Global Surgical Collaborative. What was the aim of this guidance? It needs to be dynamic. It needs to be updated from time to time at both websites. And it was important to provide practical guidance to the surgical community as service regionalization as well as practical steps during MIS. Why specifically MIS? Because the rapid fear about aerosolization and the risk to staff was growing at this time, to the extent that a number of guidance was asking to stop laparoscopic surgery. We did not have any evidence to support this during MIS, specifically with COVID-19, but there has been some data from related similar viruses. No evidence, it did not mean that it doesn't exist. And we had to be in the cautious side to protect our staff and our patients. So what are these guidance? Basically, we issued a number of statements suggesting to suspend all non-essential surgery. And all non-essential staff, they should be working from home, so as well as meetings, including MDT. And that was the start for our virtual, pretty much meetings, which were in some places we're still continuing this. Minimizing site visits. As for OR, we recommended to develop a pathway, clean pathway, and a suspected pathway, and don't mix them together. And importantly, testing all patients before to come to surgery 72 hours and to have self-isolation before, which is interestingly still practiced till now in my own hospital. Patients' partnership is very important, and consenting and counseling them about the risks, even if they did not have COVID, they may acquire it during hospitalization, especially if they're coming for cancer surgery. And that was a very important issue. Issues related to the environment in OR and preferable negative pressure, as well as the anecdote of a period of rest of 20 minutes. That was all practiced as the initial phase of the pandemic. But it was more important that to minimize the number of staff around. And that obviously affected training and education, as you're aware. However, all the staff who are available and present in OR must wear PPE. And that was obviously recommended, the N95. And that was regardless to the COVID status of patients, which continued across the pandemic. What about procedures for MIS? Well, obviously we try to minimize the leak of gas. So small incisions, keep the pressure low, use the device to filter which carbon dioxide, which I'll go through them in a minute, and minimize the use of surgical trains. With energy, to minimize the use in general and using a low setup, and definitely using filter when you're using the energy sources, and pneumoperitoneum should be safely evacuated, not into the OR room. We published a number of closed evacuation systems, which pretty much fit in with every single device that will safely evacuate the carbon dioxide without circulating it in the room. And that was very, very important. We must not vent pneumoperitoneum in the room, which is, to be honest, a safe requirement anyway. We published all of these along with a smoke evacuation system in both websites, and they kept updated. And I'd like here to thank the industry of various companies for collaborating and working together to provide a very comprehensive list and useful to our members. We published these guidance on the 30th of March 2020 at both websites, and then published a surgical endoscopy using an infogram, which has been highly cited across the social media. And then very important to know that although it's published very recently, surgical endoscopy has been highly cited and is ranked at 4th in the surgical endoscopy, the SAGES and EAES recommendation for MIS during COVID manuscript. Looking at a couple of countries just to see what is that impacted on practice of guidelines. This one is the Italian survey across 220 surgical departments, looked at the various phases of the pandemic. It's very healthy to see that laparoscopic surgery has been maintained during the first and second phases, so as the use of smoke evacuation systems. We looked at 84 hospitals in the UK in a small survey we carried out, and it's really important. We did ask them specifically how useful they find our statement of recommendations, SAGES and EAES, and it's very healthy to see over 90% they found it either very useful to essential requirement. But importantly, it was very important to see that utilize the contents of the recommendation, especially about a special measure during MIS. Where can I summarize? Yes, the COVID pandemic is still presenting a number of challenges to the whole surgical community. But within these challenges and the concerns that presented an opportunity for the leadership to stand out, for SAGES and EAES, and work together and deliver useful guidance to our members and our surgical community that can maintain safe application of MIS for the benefit of our patients. I'd like to acknowledge and thank all who are contributed in this project. Thank you.